الله الرحمن الرحيم. عشان برضو the sake of time ان احنا متأخرين حوالي ربع ساعة. الجلسة دي على الانترفنشنال بالمونولوجي، ويشرفني ان ابقى كو شيرنج ذس سيشن مع اخي العزيز الاستاذ الدكتور علاء الشلبي، الاستاذ الدكتور عماد قراعة، و our dearest friend سباسوجي بابوفيتش، والاستاذ الدكتور محمد حنتيره وزمانه جاي. هنبتدي اول محاضره مع الاستاذ بروفيسور لورينزو كوربيتا. and Professor Lorenzo Corbetta is a very well-known authority in intervention pulmonology. He's Associate Professor of Respiratory Diseases, University of Florence, and he's the Director of Education Program in Interventional Pulmonology. Thank you for being with us, Professor Corbetto, and you can start your presentation. Thank you.
Thank you for your invitation, and to see this wonderful country. And I introduce, I'm the first in this session, so I introduce interventional pulmonology as from a training point of view. Because interventional pulmonology can be defined as the art and the science of medicine related to performance invasive procedures for pulmonology, for respiratory diseases that required in a standard pulmonary medicine training an expertise beyond that required in a standard pulmonary medicine training program. So this is very important to know, because the specialty doesn't teach all the procedure, but sometimes neither the basic procedures for bronchoscopy. And this is very important because we are lucky as pulmonologists, because we have a hole to enter inside the bronchi and the lung. And so everybody, every clinic will ask the bronchoscopist to look inside the patient. So we have to know how to look inside the patient. And in the last 20 years, we have a huge increase of new procedures. Have you seen from rigid bronchoscopy to stent, to navigation, to ultrasounds, treatment of asthma and COPD. So it's very difficult to teach interventional pulmonology during the specialty training. So for this reason, in the United States, they published this article of Carla Lamb of the American Academy, who suggested a dedicated year of additional fellowship training for interventional pulmonology. But the mastery of these skills is an ongoing process in practice, extending beyond the interventional pulmonology fellowship. It's very important to know what is competence. Competence in medicine means to make use of not only knowledge, not only skills, but also communication, clinical judgment, emotions, values, and critical reflections. And this certification of competence is very important to ensure safety of public and advance in some specialty field. And we believe that the training could be done in a structured learning with almost 1 year, at least 1 year of fellowship, with a structured learning, with dedicated time, with a precise curriculum, with program director, a faculty of experts. But in the world, except only some countries, as United States, and also, fortunately, in Italy, we used to train during the practice. So for us, the formal training is very important because for the formal recognition of our specialty. And this recognized field of interventional pulmonology can attract the best and the brightest to commit their careers. 3 years ago, the World Association of Bronchoscopy and Interventional Pulmonology asked me to write an editorial about the European situation. And after a survey, we realized that at the present we don't have a single common curriculum throughout Europe, and nor a certificate of competence in interventional pulmonology like in the United States. So there is a great need for a roadmap leading to European standardization and certification also in Europe. And this was confirmed in this article with Hans Lee, who is an American director of the Association for the Fellowship, that the approach in Europe and USA is completely, of training is completely different. What we have in Europe? In Europe, as structured learning, we have the European Respiratory Society that organize this training program only for EBAS. But there is the plan to go also to other procedures like thoracoscopy, ultrasound, but for the moment there is only the board certification for European for EBAS. 2 years ago, we collect many experts in the world to talk about the standardization of training and competence in international pulmonology in the world. There were Italian, European, but also from South America, from China, from other countries. I hope in the next edition, I hope to have also an Egyptian. And the conclusion of this conference was well summarized by Eric Holt, who is the guru of the training in interventional pulmonology, that is the end of an antiquated education model, historically linked to a see one, do one directly, and teach one. But the patient must not be used as subjects for medical procedure education, because we have many new tools and we have to organize specific structured training programs in every country and maybe in collaboration with many countries, and we need also the trainer programs. In Italy, we are at the 13th edition of a structured training, 1 year structured training. So we improved year by year the number and the age. You can see here is the average of 40 years old, and the number of applicants, the participants, increases till the COVID, and then last year reduced. I hope in the future to turn back, to get back to this number, and maybe female and male the same from all Italy, but also from many foreigner countries. The last year we had also from Philippines, from Colombia, some participants, because now for many reasons. One very important is that this university is a university master, and the certification is valid as a curriculum title. So some participants come to have this kind of certification in advanced procedures. And The track from these 13 years was step by step. The first step was to delineate a specific competency, the core curriculum of interventional pulmonology. The second, to develop the methodologies, and the third, to develop the specific measure of this competence, the assessment. We reported the curriculum and all this information in a publication that is available free, and where we have 12 chapters, one for every procedure, where we describe the knowledge, the skills, the methodologies for training, and the methodology of assessment for every interventional pulmonology procedure. This was also recognized by the American Academy in the official journal of bronchology interventional pulmonology. The second step was to improve the methodologies. For the lesson, for the frontal lesson, especially with the COVID, we improved our digital communication, and this permits us to publish, to upload all the presentation in a YouTube channel that permit, for example, the translation, the immediate translation in every language. Here you can see in Arabic. So it's easier now to organize an international master, also in a country where English is not the official language. And we have many foreigners, international experts from the United States, from Europe, but also from China. And another improvement is the possibility now this is our operating room, is to have the possibility to publish also the life inside our operating suite. Every day of the master, we connect with our operating suite and we transmit what is doing the operator, the bronchoscopy videos, the EBUS, the navigator, the video microscope, the fluoroscopic guide, the presentation of the case. And this is transmitted online directly via the video conference platform, with the permission, of course, of the hospital, of the patient. But it's like an internship, because you can see, you can discuss with the operators, with some commenters, with some doctors, what is happening in the operating suite at low cost, because we use the system, the video system of the operating room, and a very easy platform. Here you can see, for example, the intubation of the patient, and then all the procedures connected with the procedures. For example, the EBUS commented and discussed in video conference. Here is a radial EBUS and so on. But another tool very important is the simulation. Simulation, because it's not possible to pass from theory to practice directly, but it's recognized that simulation improve and accelerate the competence, the skill in the practice. Using low fidelity on plastic model simulation, using the swing lung, for example here, for a simple TBNA, but with also the possibility to demonstrate directly the rapid on-site evaluation with the help of cytopathologist, but not in the patient, but in the animal. We have a very advanced high fidelity simulator, like Symbionics, for example. The problem is when we have to go to the supervised practice, because Stater demonstrated that in the hospital where there is a training center, the complication increase in comparison to the hospital where there is no training. So we need to solve this problem of insurance, for example, for the participant, for the trainees. At the end, the assessment is very important. The quantification tools like the pilot are important but not sufficient. This is what is required by the American Academy to be considered competent, but not only, because we need also qualification tools. We use, for example, the BSTAT. They finish? We use some scores to demonstrate the competence. Thank you. I finish, but the better solution is to measure and monitor the outcomes and performance quality directly. That is more difficult, but we need it. At the end, is the conclusion, the success and future of bronchoscopy interventional pulmonology depends largely on giving residents extensive training opportunities in which they can learn procedural skills in a safe environment without putting patient at risk. And we have to involve and to be more and more interactive with the trainees to improve their competence. And this is how we can reach the success. Thank you very much for your attention.
Thank you, Professor Corbetta, for this excellent lecture.
Louder, please.
I agree that with you that the training, education is the most important thing now in interventional pulmonology. And now we will leave discussion for the end of the session, if you all agree. I would like to introduce my dear friend, Professor Emad Khoraf from Cairo, who is going to speak about bronchoscopic intratumoral chemotherapies for non-small cell lung cancer.
Okay, hello everyone. Thank you, Chairperson. Gonna talk today about the intratumoral chemotherapy. Well, to start with, the central airway obstruction in patients with lung cancer limited to the thorax. Lung cancer is one of the most common malignancies all over the world. Among those patients, central airway obstruction is a major problem really, facing all medical and surgical subspecialty caring for patients with lung cancer. About 20 to 30% of newly diagnosed patients with lung cancer will develop complications such as respiratory distress, bleeding, atelectasis, post-obstructive pneumonia, etc. In patients with this complication, morbidity is significantly high. However, if left untreated, death from suffocation is a frequent outcome and is a major problem. It is obvious that in such cases, life-threatening obstruction of the airways, there is an urgent need for rapid recanalization of the airways. In the past, كان بيستخدموا دايما extreme beam radiotherapy for treatment. إنما, however, these studies have shown poor results for irradiation alone. For that reason, radiation alone was no longer used and as a standard therapy for lung cancer limited to the thorax. Today, the standard care nowadays is for inoperable localized lung cancer is concomitant radiotherapy and systemic chemotherapy. Drugs used for systemic chemotherapy including the cisplatin, the paclitaxel and carboplatin, and shows really efficacy in the treatment of chemotherapy. However, again, systemic chemotherapy with irradiation does not act as quickly as needed to establish a free airway passage to prevent the morbidity and mortality for those patients. Therefore, it has become important to develop a new localized adjuvant endobronchial treatment, such as the different interventional procedures used. So in general, and at the present time, local treatment options including the Nd:YAG laser, the photoresection, the cryotherapy, electrocautery, argon plasma coagulation, brachy, and photodynamic therapy. Actually, there is no modality has proven clearly superior to the other, and the choice of the endobronchial intervention is generally dictated for the patient stability, the nature of the underlying problems, the quality of life of the patient, the experience, personal experience of the physician, and the technology available in the particular institution. Currently, the most successful strategies employ systemic and several combined local intervention modalities, which is called the multimodality treatment, and this is very important. It has been shown that initial debulking of obstructed airway by Nd:YAG laser photoresection or by cryotherapy lessens morbidity and also may shorten the hospitalization and improve the quality of life of patient. However, all these interventional bronchoscopic methods are designed for acute therapy of the airway occlusion and do not treat the underlying disease. That's why we should continue the treatment with the interventional bronchology with other types of or other modalities of therapy. Here comes the endobronchial intratumoral chemotherapy that can be considered an important and effective new adjuvant therapy for management of lung cancer. The majority of patients with non-small cell lung cancer have disease limited to the thorax, which makes the tumor mass easily accessible by the bronchoscopy. Actually, this idea was started with the invention of the bronchoscopic needle catheters to introduce multiple drugs, many drugs into the tumor site. The needle catheters is used for transbronchial needle aspiration by the rigid bronchoscopy or flexible diagnostic bronchoscopy, and there are flexible catheter, and as my friend Popovich said yesterday, we have the rigid catheter also used for endobronchial injection of different drugs. What is the technique and the equipments used for intrabronchial chemotherapy or intratumoral chemotherapy? This can be performed through any model of standard flexible bronchoscopy and can be done under local anesthesia as well. So the patient may come as an outpatient clinic, in outpatient clinic patients to be injected and return home at once. This mode of treatment does not require any special accessory except an ordinary transbronchial aspiration needle biopsy. Direct injection are carried out weekly for 3 weeks. Day 1, day 8, day 15, and day 21. 4 sessions in 3 weeks. What are the criteria of drugs used for endoscopic intratumoral chemotherapy? The drugs used should not induce local necrotic changes in the normal mucosa, because you cannot judge exactly the dispersion of drug among the mucosa. So it must not induce any necrotic change in the normal mucosa and have pH of around 7.4. And also drugs must be chosen that do not exhibit direct anti-neoplastic activity. Exhibit direct. They do not need the liver to be transported into activation or to be activated by the liver. Examples include carboplatin, 5-fluorouracil, cisplatin, bleomycin, mitomycin, methotrexate, and mitoxantrone. Drugs that require activation by hepatic microsomes before antineoplastic activity, such as cyclophosphamide, were considered unsuitable for this direct injection. And regarding the advantage for direct intratumoral drug injection, there are several potential advantages, including the assured precision in the local delivery of the drugs. بالظبط أنا رايح فين في الدراجز بتاعتي. And also complete perfusion of drug within and around the region. Dramatically higher tumor concentration achieved by conventional systemic chemotherapy. زي بعض بالظبط concentration more than the systemic conventional systemic chemotherapy, and also they have little or no systemic toxic side effects. The intratumoral chemotherapy can uniquely provide very high drug concentration in the endoluminal, not only in the endoluminal but also in the submucosal, the intratumoral and peribronchial areas. The effect of the endoscopic intratumoral chemotherapy differs actually from other interventional bronchoscopic ablation procedures by destroying of the malignant cells with minimal damage of the normal cells. This selective action is only comparable with the brachytherapy and photodynamic therapy, but not to other interventional procedures. There are certain methods to prolong the lifespan or the stay of the high of the intramural drug concentration. يعني we inject directly اللي هو السيتوتوكسيك دراجز اللي بتستخدم انترافينوس بنلحقنها جوه الانتراتيومر، ولكن في methods عشان to prolong its stay in the tumor itself for more effective treatment. These methods including ان انا احط الدراج ده في دراج oil emulsion او احطه في دراج polymer gel composition او دراج loaded microspheres and drug containing liposomes. ده كله ده ممكن these constituents بتطول and prolong the stay of the drugs inside the tumor. So now what are the changes occur while injecting these solutions into the tumor? Well, the tumor began to be swollen and pale and become to be whiter in color during injection of the drugs inside the tumor. And this is probably due to edema of the malignant tissue and compression of the blood vessels inside the tumor by the injected solution. And shortly after injection of the cytotoxic drug, the tumor began to shrink and to lesser volume. وبعدين بعد كده there will be necrosis or necrobiosis of the tumor tissue itself, and the tissue then becomes brittle and easily separated into small fragments. As a result of this necrosis and the reduction of the size of the tumor's mass, the luminal obstruction of the airway is reduced and symptoms start to alleviate. Also, there is a delayed effects after injection of these cytotoxic drugs inside the tumor. That is 3 to 7 days after intratumoral drug injection. The tumor also further shrink, and it will be covered by a white yellow gel-like substance. Histopathologically هنلاقوها اللي هي necrotic tissue, devitalized tumor cell residues, fibrin coagulum with dissipated secretions and white blood cells. In some cases الحقيقة إنه weeks to months later the tumor may disappear completely, leaving a gray-colored scar tissue. In some cases, the observed adverse events of intratumoral chemotherapy injection. During injection of cytotoxic drugs, patient normally report no disturbed sensation. Injection of drug into normal mucosa membranes have not caused adverse events such as irritation or necrosis. Moderate chest pain may be felt by the patient, sensation of nausea and a moderate fever for 1 day duration after the injection, but with no systemic effects have been observed as a result of chemotherapy injection, and this is important. The indication, there is a multi-modality treatment plan. لازم, very important, a multi-modality plan. I may use the Nd:YAG laser, I may use the cryotherapy or the stent, then add on an intramural chemotherapy. Not alone. There is always a multi-modality plan decided by the bronchoscopist. For this purpose, a treatment algorithm combining endobronchial intratumoral chemotherapy with other endoscopic and non-endoscopic treatment modalities have been developed and should be considered. So there are 4 situations where the endoscopic intratumoral chemotherapy and other endoscopic treatment of malignant diseases are indicated. Number one, the life-threatening obstruction of the central airways. What we mean by central airways, the trachea, carina, and main bronchi, including the bronchus intermedius. And the second, the symptomatic but not life-threatening obstruction of the central airways, like dyspnea, atelectasis, or pneumonia. The third is the asymptomatic obstruction but with luminal diameter reduced less than 50% of normal. And the fourth, inoperable or operable early lung cancer and amenable to potentially curative endoscopic treatment. In conclusion, endoscopic intratumoral chemotherapy should not be simply regarded as a technique of ablation of endobronchial tumor bulk like other endoscopic ablative procedures. It should rather be regarded as a recently developed procedure for non-systemic local-regional chemotherapy. Local high-dose cytotoxic action can reduce the large local tumor burden with rapid alleviation of endobronchial obstruction with enhanced patient quality of life, and the patient may benefit from surgery later on after the injection. The intratumoral chemotherapy is extremely patient-friendly and cost-effective. So there are several reasons why there is limited clinical use up till now for this procedure. Well, I think there is a highly conservative attitudes among clinical oncologists and pulmonologists. They are always conservative in their treatment and management. And also the debulking of the airway obstruction can be realized with more well-known laser photosection that have been tried before, or electrocautery, and most clinicians are reluctant to test a new method which they are not familiar. So thank you so much.
Thank you, Professor Imad Qurra, and let us to invite another eminent professor, Professor Mohamed Hantira. He will speak about endobronchial ultrasound elastography for differentiating benign and malignant lymph nodes.
Good morning, everybody. Good morning, the Chairman. My talk today about ESSB elastography. Current non-small cell lung guidelines recommended endosonography guided needle aspiration biopsy for lymph node as a reliable first choice method, reducing the need for more invasive surgical staging. Really, in the last 20 years old, endobronchial ultrasound technology has become a major diagnostic modality. We have now the radial probe and we have the convex probe. About the radial probe, which we use to identify and the location of mediastinal lymph node, and more nowadays has a good rules in the peripheral lesions, as we heard this morning. But my talk today about convex probe. Convex probe EBIS is built directly into the distal tip of the bronchoscope, allow a real time for all the lymph nodes. So easily I can reach all the lymph node, take biopsy, make staging, and more I can make tissue immunohistotyping for the target therapy. This is the characteristic of the targeted lymph node, which must be short axis, round or oval, distended, heterogeneity, and the blood flow must be abundant to be the target lymph node to be biopsied by the EBIS. This is the map of the regional lymph node station. If we look by the endobronchial ultrasound, I can reach the subcarinal, which is 7, upper and lower paratracheal in the left and in the right. Also, I can reach the lobar, interlobar, and hilar. And by the EOS, we can reach only 2 stations, the 7 and 8. So if I combine both of them, we can do what we called medical mediastinoscopy. So if we classify the lymph node again, I have the supraclavic lymph node, which is level 1, and then superior mediastinal nodes from 2 to 6, and the aortic node, which is 5 and 6, and the inferior mediastinal node 7, 9, 8, and 9, and then the hyaline and lobar segmental nodes. And regarding the new TNM classification, if there is no nodal metastasis, it's N0. If I have metastasis in the ipsilateral level, it's which is called from 10 to 14, it's N1. I have metastasis in the ipsiabral level, and from 2 to 9, it's N2, and lastly N3 metastasis in level 1 or any contralateral node. So by EBS, again I will return to this. I can make journey in all of the lymph node, and I can put the classification of my patient. But be caution that you must turn your journey from N3 node followed by N2, then N1 to avoid any contamination and upstaging. It's really a problem because, for example, if I have this lesion, I must start by the contralateral node, then I go to the ipsilateral level from 9 to 9, and then to the ipsilateral level from 2 to 9. So I will make a long journey. From each node, I will use the same forceps biopsy because it's very expensive. Changing the needle after puncturing each lymph node is impossible. Why? Because it's expensive. In Egypt, it's about 5,000 to 7,000 Egyptian pound. So EBS TBNA may cause tumor planting and the emergencies of false positive. So I need some technology help me to decrease the buses, help me to choose the lymph node to be targeted or biopsied. So I must change my technology. That is why this is new technology, which started in the normal ultrasound, which is called ultrasound elastography, is now imaging procedure that can assess the tissue compliance. Pathophysiological process as a malignancy can lead to formation of stiffer tissue in lung cancer that can be measured by EBS elastography and differentiate the malignant from benign. This elasticity is reflected by two ways. Either strain graph indicated in nodal hardness, the colors with hard, intermediate, and soft tissue were blue, green, and yellow, or red. So blue, green, yellow, and red associated with the type of the tissue. And also reflected as a strain ratio, which is a number measured by the technology, which can be measured when there is a good contact with the transducer. A good contact means that I have region of interest. Comparing these regions with the surroundings, I have a number. So either to use the colors, the blue, green, and yellow, or to use the strain ratio. Let me go to our Egyptian experience, and I must thank all my colleagues in our department in Tanta University, my colleague Professor Adel Salah, my colleague Professor Dalia Sha'rawi, and our colleagues from pathology, Professor Ayman Al-Saqqa. We use this technology, and we publish our paper in the Egyptian Journal of Egyptian Scientific Society. We have a total 55 patients recruited in our study, all patients with hilar or mediastinal lymph node with short axis more than 1 centimeter. Any patient with cardiovascular instability or bleeding are excluded. Total 147 hilar mediastinal lymph node with different stations were examined during our study. We used the bronchoscopy procedure using Bentex, was performed under moderate sedation. Real-time ESSB mode and elastography was measurement of the strain ratio. We do it. The elastography scan range included the entire lymph node and the surrounding normal tissue. What we found, the study included 56 patients, 32 males and 24 females. Elastography and EBS TBNA was performed on the 147 hilar and mediastinal lymph node. The mean size of the examined lymph node was 2.4. This is our results. We diagnosed 111 malignant lesions and 36 benign lesions, and most of the malignant was metastatic. The strain ratio of malignant lymph node were 29, significantly higher than the benign lymph node, which is very important in our study, that the number of passes required for the diagnosis to malignancy lymph node was 1.55, which was significantly lower than those in benign lymph node. and to decrease in number of passes is very important in our job. In the malignant lymph node group, 70% of the lymph node were diagnosed from the first pass, 21 from the second pass, and 21 from the third pass, and this is with the help of our pathologist. While in the benign lymph node, 14 lymph node was diagnosed from the first pass, and the third pass was the majority. This is one of the patients. If we see there is heterogeneous of the blue and the green color, and we biopsied this patient and was diagnosed as sarcoid. So to conclude, patient with mediastinal lymphadenopathy can be sampled with less invasive, more safe maneuver using epistemin A. The specimens are not only examined cytologically, but also by immunohistochemistry, and elastography can be used as a method of discrimination between the malignant and benign tissue, decreasing in number of functional node during the station. Many thanks for attention.
Thank you, Professor Hantira, for this nice, elegant talk. And now for my professor, and I'm proud to be his, always his student, Dr. Professor Tariq Safwat, who has reinvention or rebuild the bronchoscopy unit at Ain Shams University. He's gonna talk about the role of bronchoscopy in COVID-19. Please, my professor.
Thank you, Habib. Thank you, Ahmed. Thank you very much. And thank you for inviting me in this interventional session. So, what's the role of bronchoscopy in COVID? As we all know that in the COVID area, we lost a lot of our practice, or we decreased our practice in bronchoscopy. So the introduction of COVID-19 for human-to-human transmission through respiratory droplets, it's a high-risk procedure in the COVID pandemic due to aerosolized viral particles, as we all know, and contamination of surfaces. COVID-19 pandemic has changed the way bronchoscopy is performed, and medical workers must adapt to ensure safety of both patients and staff. We all know that in our practice, and it's quite serious to proceed with bronchoscopy without having a real protection while we're doing the procedure. So my agenda quickly, over the 10 minutes of the presentation, the role of bronchoscopy in diagnosis, the role of bronchoscopy in the management of COVID, when to perform bronchoscopy, and how to perform it. These are the main topics. So, role of bronchoscopy in the diagnosis, the main reasons, if we're gonna do our proceed for bronchoscopy in COVID patient, the main reason we have to take care of the significant amounts of droplets that contaminate the indoor equipment. That's number one. And increased pressures used to oxygenate and ventilate the patients with respiratory failure. We need a lot of pressure. The close contact between the medical personnel involved in the procedure and the patient. We have to take care of these points. So let's start with this case. The benefits of BAL, if we're going to proceed here, the benefit of BAL may outweigh the risks only if performed in highly selected patients. So we're going to do the BAL in very selected patients. If the patient is immunocompromised, having pneumocystitis, cystic carinae, or whatever, and should be by experienced operators and with very strict, appropriate precautions. This was an immunocompromised patient having a lung transplant on treatment to avoid rejection, and the patient underwent a transbronchial biopsy and was histologically diagnosed as having a COVID case. That was a lung transplant patient in one of the papers. And if we go again, one of the leading roles of bronchoscopy in the context of COVID-19 is to identify the alternative infections or co-infections. Interesting recent studies reported alternative infections in up to 65% of patients, which can make our strategy in treatment, we can change it. And it facilitates the mechanical ventilation, identify bronchial migration of the endotracheal tube, and provides prognostic information. We all need, we know this. And it's important as well to perform it if we have complications like atelectasis, collapse of the lung, hemoptysis, and to solve issues and problems when we face mechanical ventilation with the mechanical ventilation. So we have to solve some problems with mechanical ventilation and collapse of the lung, etc. So bronchoscopy would help, of course, in tracheobronchial obstruction by removing secretions, and it can be useful as well in tracheostomized patients to perform the tracheobronchial toilets, to search for complications related to tracheostomy, and to carry out preliminary evaluation for tracheostomy and to see how it's fitting inside the tube or inside the trachea. And can be used as well for localization of site of bleeding, cessation, hemostasis, aspiration of sputum or secretions, and blood clots removal. It can help as well in local injection of saline, cold saline epinephrine, vasopressin, or which can be performed via the bronchoscope. So this is one of the bronchoscopy procedures, and you see how this operator is taking care of himself with the face mask, with the double gloves, and all the PPE protection. And he performed the bronchoscopy, and it showed that this patient had kappa or COVID-associated pulmonary aspergillosis. And it was here, and it was aspirated. Again here, that's another bronchoscopy in the management of COVID-19, and that was a radiological paper, in a multi-center comparative study on 2,000 patients, and it showed as well the aspergillus infections and mycetomas which can happen, and it's been proved as well during bronchoscopy that this patient had disseminated aspergillosis. So it's important in this condition, especially in immunocompromised patients. That's another indication. This patient was mechanically ventilated. He had a lobar collapse, a lot of secretions here, and it should have been performed here, and it was actually performed a bronchoscopy to relieve all and to suck all the secretions which made the collapse of the right lower lobe. So that's another indication which is important during mechanical ventilation. That's another indication. This patient had a lung resection. Actually, he had a left pneumonectomy, and he developed a tracheobronchial fistula and a left bronchopleural fistula in a COVID patient, which was confirmed by bronchoscopy. So we have actually urgent indications for bronchoscopy here. Emergency bronchoscopy should be performed if you have massive hemoptysis, severely symptomatic central airway obstruction, or the tube in mechanical ventilation. We have to adjust it, the endotracheal tube, and these are the indications of urgent bronchoscopy. Central airway obstruction, foreign bodies, tuberculosis, differential diagnosis, infection, etc. So these are the main urgent bronchoscopy procedures. This is another example. This patient was diagnosed as having by multidisciplinary discussion, and he was diagnosed as having COVID. Actually, it wasn't a COVID case. It was a lung cancer, and a biopsy was taken, and this proved to be a lung cancer patient. Maybe this is one of the, we detect some early cancer pathologies by doing X-rays, because during the COVID area we performed a lot of CTs. So we can get an early detection of a tumor mass, and we can diagnose it by bronchoscopy. So when to perform bronchoscopy during the pandemic? elective bronchoscopy should be postponed until after full recovery from COVID. We don't perform bronchoscopy until we are sure that his PCR has been negative 2 or 3 times. We can postpone a lung mass or lymphadenopathy, whatever, lung emphysis and mild to moderate airway stenosis. We can postpone this. However, a life-threatening or life-saving intervention should be performed in case of massive hemoptysis, if you have severe airway stenosis or an endobronchial obstruction. This is an urgent indication for bronchoscopy. And these were the societies which listed the indication for bronchoscopy during the pandemic. The Spanish Society listed the exceptions to the rule of delaying procedures, but immunocompromised patients, atelectasis, hemoptysis, foreign bodies, airway obstruction, these are the candidates to perform bronchoscopy. The British Society believes that bronchoscopy should be avoided for at least about a month, 28 days, from onset of infection, if the delay would not be detrimental to the patient prognosis. This is the evaluation of the operator or the pulmonologist. The American Association of Bronchology and Interventional Pulmonology indicated that the delay of the procedure until the full recovery and infection-free declaration of the patient. This was the opinions of different distinguished societies. And this is how the setup when we're going to perform bronchoscopy. Number 1 here, we have to have the special work, and they had the PPEs. We have to wash our hands, to put the disposable cap, put on a medical protective mask, preferably the N95, put on the inner disposable, and then put on the goggles and protective. It's a hassle, by the way. And then put another disposable gloves over the first one. So it's quite a procedure. And if we're going to do it, we have to see that during the pandemic, bronchoscopy should be performed in a negative, pressurized, or in adequately ventilated rooms. It should be a negative pressure. And we have some of these facilities in our hospitals. The healthcare personnel should be experienced, and individual enhanced third-degree protection by wearing the PPEs and face masks and protective clothing and clothes. This is very important. And by the way, the mask, if you're going to proceed, it should have the mask, it should be very well attached to the face with no leak, and then we have like a swivel adapter, and we insert the bronchoscope through the opening here, and at the same time the patient is well oxygenated. This is a kind of procedures, how they perform it, with the full coverage of the face. And by the way, the oxygen should be dry, not a humidification. So oxygen supplementation should be done without the use of humidification to avoid aerolized liquids with the oxygen, which can contaminate the room and infect the operator. If we're talking about the facility of the operating room, this is number 1. This is the dressing room where we're going to dress your PPEs, and then you go in. That's the 2 operating suites or the theaters for endoscopy. And then you go out. This is where you take off all this PPE equipment, and it should be, of course, well taken care of. And then you go from the endoscopy suite from another entrance. You go out from another exit door to avoid any problem of contamination and spreading the infection. If we have the facility to have a single-use flexible bronchoscope, it's quite expensive, but it's been adopted in some centers that the American Association of Bronchology and Interventional Pulmonology recommends the single use of flexible bronchoscopes, disposable bronchoscopes, as first line in any suspected or confirmed COVID-19 patient. Clearly, the single-use flexible bronchoscope are sterile, opened, and used only for a single patient, avoiding the risk of bronchoscope cross-contamination from one patient to another. طبعا, this is quite expensive and it needs a hell of a money. My take-home message that performing bronchoscopy in patients with COVID is not without potential risks of SARS-CoV transmission to the bronchoscopists and other involved healthcare workers. Bronchoscopy could be beneficial in highly selected patients with suspected COVID-19 who had an initial false negative test. It can help. Similarly, in early diagnosis of a secondary bacterial or fungal infection is paramount, as a misdiagnosis can negatively affect the patient outcome, especially in fungal infections. And the bronchoscopy enables the operator to perform therapeutic interventions under strict precautionary measures, which can be life-saving. And thank you very much for your attention. Thank you very much.
Many thanks, my dear Professor Tarek Safat, for this illustrative presentation. Now we close the session and we will go for a coffee break.